Choriocarcinoma. Our presenter today will be Dr. Mokomba, who is an obstetrician and gynecologist and a fellow in Gyn Oncology. You're most welcome, Daktari, and you may proceed to share your slides. We'll take questions and answers at the end of the session. Karibu sana, Daktari.
Hello? Hello? Yes. Yes. Yeah, I'm trying to. Can you hear me now? I'm on. Okay. Okay. You are getting me now. You are getting me now, Dr. Arogo? Hello? If you can be able to share the screen for me, be able to project for me. Hello?
Hello, we can hear you now, Daktari.
Okay, you are able to project for me? Sorry.
Sorry for the technical hitch. We are trying to present your slides, Daktari.
Okay. If you can project, we can continue. Dr. Arogo?
Just
Hello?
hold on a second. No, we are working on it.
Okay.
Sorry, technical hitch. Sorry. Just hold on a second.
No
The
problem at all.
team is working on it.
Okay. Can I continue?
Yes, Dr. Mokomba, you may proceed.
Okay. So today, most welcome. My name is Dr. Mokomba. I'm a gynecologist and a fellow in gyno-oncology and a senior specialist in KNH. So I wanted us to share. Okay, next. Yeah, so gestational trophoblastic disease describes a group of neoplastic conditions, that is abnormal growths derived from the placenta. And like I said, it's the most curable gynecologic malignancy or cancer. It's one type of cancer you get, you should be able to get 100% cure rate. So that's just an image of identity mole, which is a form of the benign or non-cancerous form of gestational trophoblastic disease. So the various types of gestational trophoblastic disease that we have, the first group is the non-cancerous types or benign, and it constitutes the hydatidiform mole, which can be complete mole or a partial mole. Complete means all you have are the hydatidiform mole vesicles. Partial mole, it means you have part fetal components, or you can even have a baby, a fetus who is alive, and you have molar vesicles on the side coexisting with the viable pregnancy. Then the other spectrum now are the malignant or persistent forms. You have the gestational trophoblastic neoplasia, what we call GTN. This is when you have rising beta HCG levels, but you do not have the tissue histology or tissue diagnosis. So GTN is the broad categorization, but you can also have gestational choriocarcinoma. You can have placental site trophoblastic tumor or PSTT, and epithelioid trophoblastic tumor, ETT. These are the various forms of now the malignant or cancerous forms of gestational trophoblastic diseases. So it's important to understand that. So you have the first group, which is benign and cancerous. That's the molar pregnancy. Then the second group are the malignant or cancerous forms. So the incidence varies from place to place. Globally is about 1 in 1 out of every 1,000 pregnancies. There are parts of the world where it's perhaps higher. For example, in South Africa, it's about 1.2 in 1,000. Countries of Southeast Asia can be as high as 2 in every pregnancies, for example, in Japan, or even higher in places like Malaysia and Indonesia, where you can have 7 in every 1,000 deliveries or pregnancies being molar pregnancies. Okay. Oh, yeah. Back home, the figures I have are for Kenyatta National. So we've noted, if you study the trend between 2014 and 2020, there's a gradual increase in the numbers of GTDs. You can note, like from 2014, we used to have about 10 cases, and now we are recording slightly over 90 cases every year of these particular conditions. Mind you, these are the ones who present to KNH or are diagnosed in KNH alone, and the figures could even be higher elsewhere. What are the risk factors for developing these conditions? Most of the risk factors are unknown, but we know the extremes of reproductive age. Those who get pregnant before they are 18 years of age, that's the teenage pregnancy, they stand a higher risk, and those above 40 years of age, by the time they are pregnant, the risk of getting these molar pregnancies is significantly increased. It's been noted in those with low protein diets, where there is vitamin A deficiency, where there is deficiency of animal fat and fat-soluble vitamins like carotene. That has been noted. These are things you'll find deficient in, especially those who have low socioeconomic status. Yeah, those are some of the postulates. Some even postulate some particular blood groups. People with some particular blood groups would have, ABO blood groups would have an increased risk of developing gestational trophoblastic diseases. Okay. So what's the pathophysiology? What causes this identiform moles? What has been noted is actually an abnormality in the initial fertilization, such that for complete moles, this comes about when there is fertilization by a normal sperm fertilizing an empty ovum, an ovum without genetic material. So once the genes of the sperm get into the ovum and it does not have its own genes, then it multiplies. So it's like you have a double set of the paternal genomes, such that you can end up with, it ends up with a diploid 46XX, but you cannot have a 46YY. The Y chromosome, which is for male, cannot survive on its own. So it's a duplication of the XY chromosome. And then you can have where there is, for partial moles, you have double fertilization of a single ovum, so that you end up with a triploid, three times the number of genes. So you have what we call triploidy, that is 69. In normal circumstances, your genes will be 46XX or XY, but here you have 69XXX or a 69XXY. So it's because of double fertilization of a single ovum. So what are the symptoms that will probably indicate that this particular person does not have a normal pregnancy? One, the most common is you'll find this is a pregnancy that grows faster than a normal pregnancy. The size of the uterus is larger than gestational age. The symptoms, signs and symptoms of pregnancy are exaggerated. These are people will be vomiting throughout. They'll be feeling a lot of fatigue, and it's because they have very high levels of beta-HCG. Sometimes they can have thyroid-like, toxic-like features because of the similarity of beta-HCG and the thyroid-stimulating hormone. So they might have tremors. They have high blood pressures in the first trimester of pregnancy. they might have heat intolerance, they might present with hyperreflexia because of the effect of the TSH-like effect, because of the thyrotoxic symptoms, they might have tachycardia and of course hypertension. Yeah, those are the common symptoms for those who have molar pregnancies. And of course, with the suspicion of the same, the gold standard for diagnosis of molar pregnancies when you do a pelvic ultrasound, which will pick vesicles. They might be complete or for partial moles, vesicles and partial, and you'll also have a fetus. It will show what is called a snowstorm appearance because of the presence of fluid in those vesicles and the tissues. So it gives a white and black areas. You might have ovarian cysts, large ovarian cysts, what we call thicker lutein cysts, because of the effect of stimulation by the beta HCG hormone. That is the ultrasound appearance that you'll get for those who have seen those videos of the storms, especially in the Americas. It looks something close to that. That is the photograph of the molar vesicles, molar pregnancy. So for the benign forms, that is the molar pregnancy, whether partial or complete. For complete, the treatment is evacuation, suction evacuation under general anesthesia in theater, under anesthesia. And then this is done, one has to prepare blood because if especially it's big, you can have torrential bleeding. The most important thing during the evacuation
Apologies, we seem to have lost the presenter again. Kindly wait as we sort this technical hitch.
And what is done is we just use the normal suction apparatus, then you connect it with a suction cannula and suction out the molar vesicles. And the precaution one should have is to have blood ready, because especially where the molar pregnancy is big, one can end up with torrential bleeding. The other precaution is we do not advise medical induction, like for pregnancy, to try and evacuate a molar pregnancy, because you can end up with torrential bleeding in the ward once you start having contractions. So as a precaution, it is advisable not to do the evacuation in the ward. So it is done in theater, and preferably also do not do a dilatation and curettage because of the potential of severe bleeding. The other thing we used to do was to repeat the DNC after 2 weeks, which is no longer advised, again because of the potential bleeding. And the other important point is this tissue should be taken for histological diagnosis. Next slide. Next slide, please. Yeah, so the other alternative, especially for elderly patients, those above 40, if they have had a desired family size, sometimes in some select cases, they can be offered hysterectomy as an alternative treatment, because you remove the uterus without the molar vesicles. This is also offered where you have a patient with torrential pervaginal bleeding. After evacuation, then this patient are followed up for a period of 1 year. It is recommended we do beta HCG levels every 2 weeks at least. Where they have resources, they do it weekly, but you can do it every 2 weeks until they are normal, then do monthly for a period of 1 year, and put this patient on oral contraceptives to prevent pregnancy, because you don't want confusion when the patient bleeds, whether they're having a recurrence of this disease or it's from the pregnancy. Next. And next one, please. I think we have discussed that. Let's go to the next slide. Next slide. No, the previous one. There's another one. The previous one again, please. Yes. So I want to move on to the next one, the one you had shown with GTN. Yes. So GTN, this is basically gestational trophoblastic neoplasia. This is the malignant or cancerous form of gestational trophoblastic disease. And this is a diagnosis is made when there is a rising beta HCG levels or they are persistent, even without histological diagnosis, and this is normally adequate to start treatment. Also, this is made if there's a tissue diagnosis of choriocarcinoma, invasive mole, placentocele trophoblastic tumor, and epithelioid trophoblastic tumor. Or if there is persistence of beta HCG levels 6 months after evacuation of a molar pregnancy. Next. Next slide, please. Next one. Yeah, so for that is the criteria for diagnosis of GTN. One, if after molar evacuation, you have 4 values of plateaued beta HCG level for a period of 3 weeks. That's the levels don't rise or drop beyond 10%. They just persist there for 3 weeks. Then that if after molar evacuation, there is a rise of more than 10% of beta HCG levels for 3 readings over a period of 2 weeks, day 1, 7, and 14. Or if there is persistent of beta HCG levels after 6 months after molar evacuation, or like of tissue diagnosis of choriocarcinoma, PSTT, or ETT, or invasive mole. So these patients, once the diagnosis is made, then they need to have an evaluation so that you're able to place them in the correct category for purposes of treatment. And you need, the investigations we need is, one, we need a complete physical and pelvic examination, because these patients tend to have vaginal metastasis, which can bleed a lot. Need to have a baseline beta HCG levels, because you'll use this as a scoring parameter in placing the patient in the right category of treatment. Chest X-ray as a bare minimum, where we have a facility like at Kenyatta, you should do a CT scan of the chest for lung metastases. You should be able to do an abdominal ultrasound for liver or renal or splenic metastases. Of course, if the chest imaging is positive for metastasis, then one should do a brain MRI or CT scan to rule out brain metastasis. Next slide, please. Next slide, Tafadhali. Yeah, let's go to the next one. That's how I've discussed that. Next slide. Yes. So there is a figure staging for GTN. Stage 1 is when disease is confined to the uterus. Stage 2 is disease is outside of the uterus, but still within the genital structures. Stage 3 is when the disease extends to the lungs without non-genital tract involvement. Stage 4 is distant metastasis, when this choriocarcinoma has gone to the lungs, has gone to the spleen, has gone to the kidneys or the brain. That is stage 4. Then what we use for treatment is now what we call the risk scoring. And this is a system that was developed under the International Federation of Gynecologists 2000, figure risk scoring 2000. So it combines various parameters which we use to determine in which treatment category the patient falls. One is age, whether one is 40 years and below is a lower risk, above 40 is high risk. The antecedent pregnancy, whether before the diagnosis of Gtn One had H-mole, term pregnancy, an abortion, yes. And then the interval from the antecedent pregnancy, whether it's 4 months, 6 months, or above 6 months, then you score as per the duration. Then you have the pre-treatment beta HCG levels. So you should be able to have a quantitative beta HCG, because this is important, it's used in scoring. Then the largest tumor size, whether the tumor is in the lungs or the uterus, you take the size and then you score it as appropriate. Then the sites of metastasis. If they spread to the lungs, that is recorded as low risk. But if there is metastasis to the liver and the brain, kidney and the spleen, that is categorized as high risk. And then the number of metastases, you count the number of metastatic sites that is used for scoring. And finally, if the patient has had prior failed treatment like chemotherapy, then you score as appropriate. Patients who score low risk are the patients who score between 1 and 6. Those who score between 7 and 13 are categorized as high risk. Those who score above 13 is ultra high risk. Okay. All right, let's move on. So that is the scoring parameters. Those are the scoring parameters. Let's move on. Yeah, the next slide now is the treatment we give. For patients who score the risk score is 6 and below, most of them are treated with single agent chemotherapy. And the two drugs most commonly used is methotrexate or actinomycin D. And it has been shown actinomycin D gives superior outcomes to methotrexate. So one can either give, like I said, methotrexate, or can give actinomycin D. Methotrexate can be given as IV doses on alternate days. You alternate with what we call folinic acid to counter the side effects of methotrexate from day 1 to day 8. Or there's a regime where you can give methotrexate every day for 5 days. Then you are supposed to repeat these treatments every 15 days. So day 1 is the day you start the chemotherapy, and then day 15 you start the next cycle. For actinomycin D, the one we use at KNH is the one where you give methotrexate 0.5 milligrams IV for 5 days, and you repeat that every 15 days. You can also give what is called a dense dose, where you use 3 times that dose, about 1.25 milligrams of actinomycin D, which is given every 2 weeks, once every 2 weeks. But the commonest is the one I've alluded to, where you're using 0.5 milligrams daily for 5 days, and then you repeat every 15 days. So this is done until the beta HCG levels become negative. So once you have the first negative, and negative is beta HCG of less than 5 international units per ml. So if you have a single reading of below 5, then you give 2 more cycles of chemotherapy, what's called a consolidation dose, before you stop. This is to avoid recurrence of this particular tumor. So this is in patients who are scored as low risk. So once you get that negative recording, then you follow this patient with beta HCG levels. It's the most accurate tumor marker of all the cancers in the human body. So you follow up this patient every 2 weeks. You do the beta HCG levels for a period of another 3 months. Then you can do monthly for a period of 1 year. And the patient has to be on contraception to prevent a pregnancy. Then you can declare the patient cured. Now, for patients who score high risk, these are patients who score above the risk scoring, they score above 7, they are put on combination chemotherapy. Let me add, before I leave the low risk, there are a few patients with low risk who we put on combination chemotherapy. For example, if the beta HCG levels are above 100,000, then we'll start on combination. It's been shown if the beta HCG levels are that high, then it means they have a high tumor volume, and later they develop resistance to single agent. So it's better to put them on combined therapy. Those with multiple metastases, even if it's the lungs, though it's a low risk factor, then they should be put on combined chemotherapy, and it gives better results. So for those who are high risk, above 7, those who score the risk score above 7, then we put them on combined chemotherapy. And the gold standard for this is a regimen called EMACO. EMACO is etoposide, methotrexate, actinomycin D, and then cyclophosphamide and vincristine. So on day 1, they are given etoposide and methotrexate. Then day 2, they are given actinomycin D and etoposide. Then day 3, they are given folinic acid to counter the side effect of methotrexate. Then on day 8, we give vincristine and cyclophosphamide. And this is repeated every 15th day, meaning you count from the day 1 is the day you start the chemo. By 15th day, you start again. So you are giving the patient only a break of 1 week for some tissue recovery from the effects of the chemotherapy. There are patients, those who are ultra high risk, can either be given the EMA regimen or they are given what we call EMA-EP. EMA-EP is etoposide, methotrexate, actinomycin D. Then they are given etoposide and cisplatin as every 15 days also. So this is also given until the patient scores 3 negative readings, or after the first negative reading, you give 2 consolidation cycles of chemotherapy. And then after that, follow this patient for a period of 2 years. For high risk, you follow them for 2 years. So you cancel the patient to avoid pregnancy for that duration. They should be on contraception. The other category, those who are given single agent and they have a rise in beta HCG levels for more than 2, at least 3 readings, then this patient should be converted to combined chemotherapy. Or if there is an increase in levels of at least 10% compared to the previous level of a period of 2 weeks, then we need, that is resistant single agent, we should convert to combined chemotherapy. The other options of treatment, next slide, please. That I've explained on when to convert from single agent. So the next one is, there are other treatment options, surgery in selected cases. For example, we had a patient in the ward. After, as we are doing the major round, she started having profuse bleeding, vaginal bleeding. And we literally ran to the operating theaters and did a hysterectomy, and that saved her life. So patients with profuse bleeding can be salvaged with hysterectomy. Patients with persistently high levels despite treatment, high beta HCG levels despite chemotherapy, do benefit from hysterectomy, and that reduces the number of cycles they are given. That is if, especially they are finished, they are family sized. But of course, if they bleed profusely, their life becomes more important. Sometimes if there is a large nodule in the lung that is not going away, they can have a lobectomy or excision of that particular lung metastasis. If there is a single big lesion in the brain causing pressure symptoms, they can have a craniotomy, but it can be very risky because these tumors tend to bleed a lot. For brain metastasis, there is also the option of radiotherapy. Patients also who have acute bleeding, especially with vaginal metastasis, sometimes they can be given rescue radiotherapy for about 5 sessions or so. That helps to cut off that profuse bleeding. So these patients, like I said, you need a very good structured program for follow-up. So I think I'll end there and then invite questions and comments on that brief presentation. So it's basically an overview of gestation of trophoblastic diseases. An apology on that disappearance because of, I think, network issues.
Apology accepted. Thank you very much, Dr. Mokomba. We have a few questions for you on the Q&A section. I'm not sure if you're able to see them, but I'll start from the top. Which blood group is at risk of GTN?
Yeah. It's I think blood group AB is the one with an indirect association.
Okay, so blood group AB. The second question, Dr. is, can molar pregnancy also cause ectopic pregnancies? That's from Lillian Nekesa. No,
because it cannot cause, but you can have a molar pregnancy almost presenting like an ectopic because of bleeding and cause pain, or if there is implantation of the molar pregnancy in an ectopic site. So on its own, it doesn't cause ectopic pregnancy.
Okay. Joseph Chebon is asking, the cases in KNH seem to have been rising gradually from 2014 to 2020. Is it due to referral to regional facilities or improved diagnosis? How do you describe its distribution in Kenya?
Actually, the rise is, it's both factors. People are more aware and they're able to make a diagnosis, and then now there are a lot of referrals. Actually, it's recommended that this condition for better outcomes is handled in specific centers where you have gynecologists and medical oncologists so that you achieve the best outcomes. And currently, the two centers that can handle that efficiently is Moi Referral in Eldoret, Kenyatta National Hospital, and hopefully Kenyatta University Referral Hospital will catch up.
Okay. Assuming Hubesi says this is a very good presentation, does the same management apply to prevent choriocarcinoma after an abdominal pregnancy with the placenta left in situ?
Yeah, with an abdominal pregnancy with a placenta, that does not convert into cancer, because that will be a normal placenta. Actually, the body autolyses that placenta on its own, or you can give methotrexate, but it does not convert into choriocarcinoma.
Okay, thank you. That's well noted. It does not convert into choriocarcinoma. Eric Wanjala is asking, is there an optimal time during suctioning and evacuation to collect the histopathological specimen, or do we submit all the evacuated tissue?
I think the best thing is to submit all the tissue, and the pathologist will isolate. They normally take samples from different quarters, because if you take one, you might miss.
Okay. Salima is asking how many HCG level tests should a patient do to be declared disease-free? What's the standard recommended unit for HCG? Because different labs use different units, especially when the tests are done outside Kenyatta.
You need at least 3 negative readings. That is readings below 5. And normally they should be done in the same lab because of that difference in reference values. So preferably you should do them in the same lab. So once you have 3 values that are negative, then you most likely this patient is cured of this disease.
Okay. Austin Odongo is asking, what happens in case a patient has seizures and was on carbamazepine earlier? Do you still do oral contraceptive for the same time?
Yeah, I think he's asking about carbamazepine and oral contraceptives, because this the anti-epileptic drugs, they tend to reduce the potency of the contraceptive drugs. This is a patient, then you advise to use dual methods. They should use condoms and the contraceptive pills. Let me add also, most times we receive patients who are high risk, have a lot of metastasis because of missed diagnosis from the other centers. You have a patient who is done an evacuation or manual vacuum aspiration MVA for, say, an abortion. Then after 1 week, she bleeds. The ultrasound shows it's incomplete evacuation. Then it's evacuated again. After the 3rd week, again, the patient comes back. So if you do it twice and the patient continues to bleed, then your index of suspicion for molar pregnancy should be raised, because it's unusual that you'll do an incomplete evacuation more than twice. And we have seen patients who are referred and they have had evacuations 7 times. So by the time you get them, they have extensive lung metastases, they have brain metastases, then the outcomes are poor. So it's important where patients bleed after a term pregnancy or after an evacuation for an abortion. If they are persistent bleeding, please think of GTN. Do the beta HCG levels, and you might be able to save the patient's life.
Okay, thank you. Professor Valentino is asking, please comment on the importance of submitting all evacuation materials after incomplete or even termination of pregnancy to rule this out. I have diagnosed a few hydatidiform mole accidentally, the same with placental in case of IUFDs.
Yeah, the professor is right. Normally, any tissue removed from the human body ideally should be submitted for tissue diagnosis, whether it's an abortion, a molar pregnancy, or an ectopic. Some of the molar the missed abortions, blighted ovum, could actually be molar pregnancies. So ideally, we should be able to submit these tissues for histology. Just like we do for after any surgery, you should submit these tissues for histology.
Okay, thank you. Vincent Shikuku says, thank you for your presentation, Dr. Mokomba. Maybe I would like to know your advice on this issue. Previously, you talked about contraceptives, which are known to cause cervical cancer, while taking contraceptives prevents ovarian cancer. What advice can you give?
Yeah, the association between oral contraceptives and cervical cancer is indirect. It does not directly cause cervical cancer. So the advantage of taking outweighs the potential indirect risk of causing cervical cancer. Because for cervical cancer, what it does is it increases what we call the transformation, the area of the transformation zone, which is liable to infection by HPV. So on its own, the oral contraceptive pills do not cause cervical cancer. So that we set it clear, it's an indirect association. So the benefits of using outweigh any potential risks.
Salima is saying the cost of HCG is prohibitive, and years back, majority of patients were lost to follow-up. What is KNH doing to make it cost effective?
At least the lab is able to do the beta HCG levels. Yes, the cost sometimes can be high, but the cost of not doing follow-up and having a recurrence is higher, because then you get the patient when you have metastatic disease, which is difficult to treat. Actually, we've had patients who go, you treat them, they disappear halfway, they come after 3 months, and they have brain, chest metastases, and whatever you give, we end up, these are the kind of patients we lose. So the patients must understand that this is for their own good. Though they are not feeling anything, these particular tests allow us to screen for any metastatic disease, and we are able to catch it up. And that applies for all cancers. Anybody who has been treated for cancer must be followed up minimum 5 years. Professor Juang says you should follow them for life, because the potential for recurrence is high for any malignancy. And for better outcomes is to be able to get this recurrent early, so that you're able to institute the proper treatment.
Noted. Salima is saying excellent.
I hope that.
Salima is saying excellent presentation, and thank you very much. If you can still hear me, Dr. Mokomba, Eric Wanjala is asking, for patients with hydatidiform, is there a role for chemoprophylaxis if they're at high risk for loss to follow-up after evacuation?
Any other issue we haven't addressed?
Hello, can you hear me?
Yes, I can.
Okay. Have you got Eric's question?
No.
Sorry,
I think the internet went off briefly.
Sorry about that. Let me just repeat it again. Eric Wanjala is asking, for patients with hydatidiform, is there a role for chemoprophylaxis if there is risk for loss to follow-up after evacuation?
Yeah, that has been tried in various places, and especially, I think, Brazil, where they have a high prevalence of GTDs. It's been shown not to reduce significantly the risk of converting into the malignant forms. And then the side effects outweigh the potential benefits, and the risk of resistance to the chemotherapy if this patient eventually develops the malignant forms of the disease. So there's no proven benefit of giving prophylaxis after evacuation of an H-mole to give chemotherapy.
Okay, thank you. George Oguna is asking, is placenta accreta a risk factor?
Yes?
Hello,
No.
Dr. Mokomba.
Remember, yes, it's not a risk factor because oh, sorry. Hello?
Hello, Dr. Mokomba.
Yes, I was explaining.
Yes.
It is placenta accreta is not a risk factor. Remember, we said in the beginning, the causation of this is abnormal fertilization with formation of abnormal tissue. So the trophoblastic tissue continues to grow uncontrolled. But you know, a normal placenta is a result of normal fertilization. So you have regulation of tissue growth. So it's not a risk factor. But you can never say never. Probably it is those who have placental-site trophoblastic disease, well, that could be a potential risk factor. So not common, but yeah, the risk is what I have alluded to, probably for placental-site trophoblastic tumor.
Okay. Doreen is saying she saw a patient who had history of blighted ovum and was scheduled for DNC, but prior to the DNC had a repeat scan that was normal. 1 month later, presents with grape-like PV bleeding, beta HCG was 40. Is there any correlation between blighted ovum and molar pregnancy?
Yeah, like I said, some people actually think blighted ovum, if you did the histology, it would give you a histology like that of molar pregnancy. So there could be that relation, though we tend to assume that blighted ovum is an empty pregnancy where the fetus does not grow, but there could be a connection. Some people think that's why it's important, like Professor Valentino said, we need to take all those tissues for histology because it could potentially be a molar pregnancy, and then we are able to take the necessary follow-up precautions.
Okay. We have a question here from, he's not identified himself, anonymous attendee. Thank you, Dr. Mokomba, for your presentation. Is it advisable to give chemotherapy treatment for a patient with stage 4 of the disease?
Oh, absolutely. This is a patient you'll give the combined therapy. And like I said, this is one malignancy you cure completely, 100% cure. Yeah, so all patients at all stages are given chemotherapy. And like I said, what we use for treatment is a risk scoring, not this. We combine that with the stage. So the stage alone, any stage, this is one disease, the treatment is chemotherapy. So it doesn't matter the stage, you will give chemotherapy. And the cure rate should be 100% if it's done on time, and if it's done the way it should be done without missing, with proper monitoring.
Okay. Claudia is inquiring, is there correlation between GTN and IUCD?
No. Not one I know of.
Okay, Claudia, there you go. Not one that is known. I think that brings us to the end of our questions posted on the Q&A session. Dr. Mokomba, if you just give us take-home message, probably for the people who joined in late, what would be your message for those going out there in the peripheral facilities, those who are not able to have gynecologists accessible to them? What is that one message that you'd like them to take home with them to their facilities?
So gestational trophoblastic diseases, that is identified from mole and choriocarcinoma, if I may put it that way, we are seeing a progressive rise there's an increase in the incidence of this disease. And this is a curable disease. If it's picked early, we can be able to treat these patients to complete cure. And as we have seen, it affects relatively young women who are productive in society. So we should have an index of suspicion where a patient is persistently bleeding, either during a pregnancy or after an abortion or a term pregnancy. At least we say do a baseline, just a basic pregnancy test. If it's positive, and at least it raises your index of suspicion and you're able to do more tests. Most of the county and sub-county hospitals now have ultrasound machines. The patients can be able to be done an ultrasound. And more importantly, proper physical examination, history taking and examination will be able to pick out most of these cases. So let's pick them early, refer them early so that they are started on treatment early. As we develop more cancer treatment centers, hopefully, then the patients will have easy access to these particular centers. And even if patients, I mean, people can call and they are given the regime to start the patients on, and they are able to have this chemotherapy started, especially at the county hospitals, and it can be done.
Okay. Thank you very much, ladies and gentlemen. That brings us to the end of this session today. Dr. Mokomba, we are very grateful for this presentation and for your time. We really appreciate it. On behalf of the technical team behind this, the KNH research team, our gratitude to all of you for attending and for posting your questions here. And Dr. Mokomba, God bless you. Thank you very much. God bless you, everyone. Have a lovely afternoon.
Thank you.